If you're nearing or over 50, stay tuned. One of the most common medical complaints of people over 50 is back pain.
And on today's Health Talk, a spine surgeon will talk about various treatments for back pain, including minimally invasive surgery.
He'll also dispel some common misconceptions about back pain.
So don't go away, we're up next. Hello, I'm Dr. Eric Mazer.
And I'm Dr. Andrea Peterson. Today we're going to talk about back pain, a problem that many can relate to.
Many, if not most, I think. And joining us is Dr. Neel Shah. He's a spine surgeon with Danbury Hospital, actually new to the community. Right. So welcome to the Danbury area. Welcome to Fairfield County. We're great to have you.
And to Health Talk.
And I'm sure we've got some backs around here that could use some help. So your interest is back pain. You're an orthopedic surgeon. Right. So let me just take a step back. We hear about neurosurgeons doing backs and orthopedic surgeons doing backs, and same for necks. I mean, how should a patient choose between the two specialties?
I think that's a great question. I think looking back historically, the neurosurgeons and orthopedic surgeons used to work together, whereas when you needed some kind of decompression next to the nerves, the neurosurgeons would handle that. And when instrumentation was needed, like screws and rods, the orthopedic surgeons would handle that. But as we move forward today, neurosurgeons and orthopedic surgeons basically do the same thing. So I operate on the neck, the thoracic spine, as well as the lumbar spine. The only real difference is if there's something inside the spinal cord that needs to be taken care of, like a tumor, the neurosurgeons are more well equipped for that, and we're more well equipped for complex instrumentation.
So a patient would know that before they go into surgery if they've got a tumor in the spinal cord, because they'd see that on MRI. Yeah. So I think the basic thing is choose the doctor, not necessarily the specialty when it comes to neck and back surgery.
Yeah.
So maybe you can kind of set the stage for our viewers a little bit, talking a little bit about some of the common reasons to have neck pain, and then we can move into some of the treatments.
Sure. So looking at neck pain, I think a lot of the reasons, there's two separate kinds of neck pain. There's just neck pain by itself, which may be secondary to arthritis or a pulled muscle in your neck. And then you talk about neck pain with a disc problem, where you have a ruptured disc or a disc herniation, which would cause a nerve to be pinched. And that would present with pain in your neck as well as pain in one of your arms, along with either weakness or numbness.
So pain that's just straight in the neck itself is probably either muscular or due to stuff that's the joints there, but a pinched nerve usually travels beyond the neck.
Of course, yeah.
So that's what you're looking for.
Yeah, that's pretty important to me, because that would really dictate my treatment and where I would kind of go with a workup with it.
Now, a lot of people think, okay, I've ruptured a disc, and this goes for the back too. I've ruptured a disc. It's pinching the nerve. It's broken. It's got to be fixed. Yeah. So they think surgery is an absolute necessity. And I think maybe even we all thought that 30 or 40 years ago. That's not true today, is it? Maybe you can say a few words about that.
That's not true. I think there's a couple situations where surgery is somewhat urgent, and that's when you have a concerning weakness in your leg, or bowel or bladder issues. That means some of the important nerves that innervate those regions of your body are being compressed, and that actually is a surgical emergency. But other than that, if you just have shooting pain down one of your legs, maybe a little bit of weakness, but you're still functioning okay, or some numbness, that can be treated conservatively. And a lot of the treatment options for that are just treating the symptoms, kind of like treating a cold. You're not treating the virus.
So again, taking the layperson's view, the disc is there, it's pressing on there. You got to fix it. It's like a broken. But again, we know that the body can even heal that too.
Exactly,
right?
and that's what it is. You're treating the pain until your body can hopefully, in layman's terms, eat up the disc and kind of take it away, so the nerve isn't being compressed anymore.
Well, that's one of the amazing things. Again, as Andrea knows, I have my own series of back pain. But with MRIs, we're beginning to see more and more that if you can wait a long enough time, that these discs actually resorb and get better on their own. And probably, maybe you could tell us, how in the world does that happen?
I mean, I'll give you a great story. I remember looking at an MRI before I saw a patient in the office, and I walked in being like, your left leg must be killing you. You're probably going to need surgery. And the patient's like, yeah, it hurts a little bit. And she did great, and I saw her back a couple weeks later, and her pain was gone. She had a massive disc herniation. She was doing fine. So, I think the adage is treat the patient, not the MRI. And our bodies they're amazing. They can heal themselves.
So
I've heard things that the hydrated disc actually dehydrates and sort of shrinks, you know, like a prune. So,
Yeah.
so you get a raisin instead of a plum. I've heard that the body itself, the macrophages, will eat up the disc.
That's what you're hoping for, yeah.
And that sometimes it
cells.
actually seeps back in the right direction. So, you know, I think it's really kind of amazing that something you think is permanently broken may actually fix itself.
Yeah.
Tell us in a little more detail, what are some of those conservative therapies while we're hoping the body is going to really heal itself?
Sure. So, you know, I like to think of it as 1, 2, and 3. 1 being medical management. So start with medications. My first line of action is usually starting the patient on a prednisone, some kind of steroid, and just to kind of get that inflammation down. Because basically the nerve root's very inflamed. It's angry. It's being squashed by the
Do you
discrimination.
see that in surgery when you actually
Yeah.
decompress those nerve roots? Do you actually see that
The nerve is usually red and injected, and it looks angry. Yeah, it's pretty.
kidding.
It's quite cool.
And I think that's actually important for our viewers to hear too, because it's not just the mechanical pushing on the nerve. Their nerve actually gets inflamed, and getting rid of or alleviating some of that inflammation is part of the healing process.
Yeah, and I think the disc herniation itself has cytokines and whatnot, which irritate
are
the nerve.
chemicals that are
Chemicals,
irritative.
irritate the nerve root. So I think that not only is a compression the issue, but a foreign body kind of being next to the nerve root also somewhat irritating.
So steroids like prednisone or others can help reduce that inflammation and help people feel better.
And I'll tell a personal anecdote. Andrea knows that I developed, just for this show, about 2 weeks ago, acute sciatica, which I will tell the people at home is the most pain I could ever imagine, and started on a high-dose course of prednisone. And really within 24 to 48 hours, there was significant relief. I mean, it really does work. It doesn't take the pain away, it doesn't make all the healing, but for people that are out there feeling hopeless, it really can work. I know that sometimes it comes back when you get off it and all that sort of stuff, but it is a very meaningful therapy. And that goes on to things like injections and things like that too.
That's a great, you know, the next step for me would be level 2 would be injections. And that's basically a directed steroid injection into the foramen, or where the nerve comes out of the vertebrae, where the disc herniation is pushing on it, to kind of cool down the nerve even further.
And that gives you a higher concentration then of that steroid right where the irritation occurs.
Exactly. And it also serves as a diagnostic tool for me, because usually the doctor that does the injections will put a little bit of Marcaine in there too. So
It's like Novocaine.
Exactly. So if in the first couple hours they have relief, I know that their pain is because of that disc herniation
That
and
particular
nothing else.
site.
Exactly.
And that's one of the problems with the back, isn't there? Is that you've got pain and you've got so many anatomic structures that can cause pain that you want to be sure that what you're fixing is what's causing the problem.
Exactly. There's so many pain generators in the back.
So even like in the patient like you described, you can have something that looks very big on MRI, but it's causing minimal symptoms.
Exactly.
Or I imagine in other cases you could have something that's relatively smaller, but can cause a large degree of symptoms
Yeah,
if
and
it's in the wrong place.
Exactly. If it's in the wrong place, it can, you know, it's just in that right place, hitting that nerve in the right way, it can cause a lot of pain.
And many people, when we look at their spines on MRI or imaging, have more than one area that looks less than pristine, shall we say. So sometimes it's tricky to know exactly what's causing the patient's symptoms.
Exactly. That's why I think a good physical examination and a history is very important, and it's better to treat the patient and their symptoms rather than their MRI, because a lot of MRIs will show, even the reports will say a lot of things that seem scary, but at the end of the day, if they're not affecting the patient, there's really nothing to do about it.
And isn't it very common as people age to have a variety of degenerative things of their lower spine? So you know, if you wait long enough, most of us will have something there.
Of course,
And it may or may not be causing symptoms.
So we talked about number 1 and number 2. What's level number 3?
So level 3 is talking about surgery.
Let's talk about surgery. You're a surgeon. Tell us about your approach, how things have changed.
Sure. So, you know, spine surgery, everyone's always scared of, because they're like, don't ever get your back operated on. I think if you operate for the right reason and you're doing the right operation for the right pathology, then the patients usually have a good outcome. Things have changed in spine surgery. Everything is moving towards minimally invasive spine surgery, which basically means less muscle disruption, smaller incisions, and that usually leads to shorter hospital stays and patients.
Now, that results in less tissue disruption, less scarring, less pain.
Exactly.
But do you get as good an operation? I mean, can you get as complete an operation with the minimally invasive methods?
I think the minimally invasive techniques that we have, if they're chosen for the right patient and the right pathology, patients do great. Just 2 days ago, I did a 4-level fusion on a patient minimally invasively through about 4 or 5 incisions about that big. And the patient's going home 2 days later, and she's doing great, whereas 10, 15 years ago, that wouldn't have been possible. It probably would have meant a big incision about that big in the middle of her back and her being in the hospital for at least 4 to 5 days.
So a lot of the pain is caused by the incision and moving the muscles out of the way and actually just getting to the point where you can see what's going on.
Getting down to the spine, yep.
When you're actually in there, do you make an effort to manipulate the spinal nerves as little as possible? Does that add to the pain?
Yeah, I mean, I think we try to be as gentle as possible because moving the nerves around themselves are going to get even more irritated. So you're going to take the compression off, but then you're going to irritate them more. So we try to be as gentle as possible, but sometimes we need to be a little bit more aggressive.
What generally goes into, say, in an office visit, if you're seeing a patient, trying to determine if they're a good surgical candidate or how you can help them?
So like I talked about, the 1, 2, 3s that I talk about, I like to bring patients down that path. And first starts with a good history and physical examination to kind of figure out what their problem really is. And then we move on to advanced imaging. So if they don't have an MRI, usually the norm is if they don't have any sort of worrisome symptoms such as profound weakness or bowel or bladder symptoms, we hold off on the MRI for 6 weeks and we try the conservative care, and then we get the MRI at that point.
Just to mention kind of as an aside, if people are having bad back pain with other symptoms like high fevers,
Sure.
Sweats at night, losing weight rapidly, that's kind of a different category of symptoms altogether, and you should be going to see a physician right away.
Of course, that's another very worrisome kind of set of categories. Then at that point you're talking about possible infection in the back or some kind of tumor or whatnot.
Yeah, that's a very, very good point.
Yeah.
I think they also recommend imaging of some type as people get older, again, because of the higher risk of malignancy.
Yeah.
So that you want to make sure that you're not dealing with a simple disc.
No.
Although to the patient with it, it may not be so simple.
What about other modes of care? Is physical therapy important in the care of back pain?
I think physical therapy kind of goes along with 1, 2, and 3. After medical pain management, along with physical therapy, I like to call it activity modification. Having patients limiting their BLTs, their bending, their twisting, and their lifting. I think that is something that can kind of flare up back pain as well as nerve pain.
So would you say anybody should be avoiding certain movements then? Well, I mean, anybody, particularly people with known degenerative disease, which would be most of us who are older. I
mean, I think people even without back pain should really, like we were taught, bend with your knees and lift with your knees. I think bending straight over puts a lot of force on our lower backs, and even someone with a healthy back can hurt themselves by doing that. So I think proper mechanics are very important.
What's the role of back spasm? You always hear about chiropractors and others, or masseuses telling you, well, that muscle's tight and that's where your pain is coming from. Yeah. How common is that, and is that the chicken or the egg when it comes to back pain?
I think that's a great analogy. I think it's a chicken or the egg. It's hard to really say. I think when muscles are irritated and they're not happy, they're going to spasm. Whether the spasm will cause more pain. So I think they kind of feed off of each other.
So we're just about at the end of the segment. Any last 5-second recommendations for our patients?
I think proper mechanics are important, and being active is very important.
And don't be afraid to see a surgeon because they have a lot of advice. They're not going to necessarily operate on you.
No.
They've got a lot of experience with this stuff. So unfortunately, again, we need to wrap this up. So thank you, Neel, for coming on the show. It's great to have you. We're going to have you back again sometime soon.
And if you viewers have a question, please do email us those questions or your comments to healthtalk@wchn.org.
Thanks for watching.
Be well.